what you'll see as we are relaying this is the fact that each tier involves being one of the components of phase one. And the breakdown in terms of timing is based on the allocation of the vaccine that we will receive. So as you see, there's a focus here on who will get vaccinated in phase one. We have started as of December 14th, and the subsequent groups within phase one, as we continue to get additional supply of vaccine, will be brought on for continuing to receive their subsequent doses. This is also where our involvement in terms of partnerships with distribution of the vaccine is critical. And so I can walk through each of these groups as we go. What's important to acknowledge is the overlap between the 5 different tiers in terms of the starting point. So we will not be finished vaccinating nursing homes, residents, and workers before we start vaccinating EMS, first responders, corrections staff, and others. It's really about a starting point and then having enough supply to continue to bring on the additional groups. We're making a lot of these decisions on overlapping based on logistics. What is the most efficient way to get the highest risk individuals vaccinated as quickly as possible? And then another important point to make is on timing. The first question everyone has is, when will each of the 5 different tiers in phase one start? There's a reason why we have displayed it this way, because we want to be dynamic in how we are determining that. It's based on the amount of supply that we receive. And in certain situations, we have much more precise certainty. For example, we expect that vaccinating will probably start in other congregate settings aside from nursing homes at some point later in January. But examples of facilities like those other congregate settings are assisted living facilities, group homes for older adults, elderly housing with residential services, and perhaps some additional other facility types. These sites will be vaccinated by CVS and Walgreens, and it will be a continuation of the pharmacy partnership currently being implemented in our nursing homes. So there's an understanding there of what timing will occur based on the populations that we're focused on and the precise numbers that we know exist in those congregate settings, starting with long-term care and the other congregate settings. But for other populations, more precise timing is challenging. There are 2 variables that have major effects on timing. One is how much demand there is for vaccine, and then the other is what I've been mentioning, which is how much vaccine we get each week. In terms of our vaccine allocations, we have already experienced and we know that there will be some variability. There will be weeks when we get less vaccine than expected. We know that, we've seen that, and we're prepared to adjust to that as we need to. On our side, we've built flexibility into our planning, so we're able to react to any changes that come our way. As I said earlier, though, if you're looking for a general timeline, people can expect us to be vaccinating phase one populations through January and through February. At that point, we'll then start with phase two populations, all also based on the amount of vaccine that we receive and the ongoing demand for vaccine. Phase 2 will include older adults not covered in phase 1. It will include other occupation types, people with certain underlying health conditions, critical infrastructure workers, and many others. So we will be sharing in a future time frame more details on phase 2, recognizing that it is a very large group. So we're in the process of working through our phase 2 plans with the subcommittee and all of our partners. In the near future, we're going to provide the public with a detailed breakdown of all the phase 2 populations in the same way that we're doing so with phase 1 today. So that's important understanding for how we'll continue to work through this process. Before I open it up to questions, I'll just finish with highlighting the how groups will be receiving vaccine. One of the key components is to ensure that communication will be made available to each of the groups that is intended in the phase 1 priority breakdown. And we already have partnerships with these various sites that we will be engaging for ensuring that people have access to the vaccines, whether hospitals doing it themselves, whether regional clinics that are through our municipal partners, or through a community site that we have set up. And we'll be sure to make clear to the priority groups the timing, the location, and access to the vaccination as soon as we have enough vaccine available to be able to distribute to them. So our takeaway overall is that our systems are working. The amount of preparation and planning that has gone into place is coming to fruition so that we're able to adapt effectively. We continue to focus on ensuring that we are distributing vaccine as we get it, as efficiently as possible, and handling logistics to get it out to individuals, and continuing to keep equity at the forefront of our approach so that we are always reaching the highest risk populations, upfront, and able to minimize disease, hospitalizations, and other impacts from COVID-19.